Good day. So for this session of bedside teaching, we will be demonstrating how to perform abdominal examination on a simulator. And to the abdominal examination, before you do any examination whatsoever, you want to introduce yourself to your patient or your simulator. You want to create a rapport. You want to seek permission or consent from your simulator or your patients. Then you also want to screen your simulator or your patients. Then you also expose the patients very well. And what do I mean by that? The exposure of a patient with for abdominal examination is from the nipple to the mid-thigh. And reason being that there are some things you have to check on the abdomen, just at the periphery of the abdomen before you start going deep into the examination. I will start the examination now. Hello, I'm Dr. Adeleke, and I want to do an abdominal examination on you. It will require me touching some parts of your abdomen. Please, if you feel pain at any point in time, please just let me know, okay? So before I start, I also want to sanitize my hand. If there is no hand sanitizer, I can request for soap and running water where I can just wash my hand before I start touching the patient. So for the purpose of privacy, I won't want to expose my patient too much. I will just have to stay at the level of the belt where the patient's trouser stops. The examination of the abdomen involves IPPA. I means inspection, P means palpation, the other P means percussion, while A means auscultation. For inspection, I want to start to check if there is any scar, if there is any distension, the position of the umbilicus, or how the umbilicus looks like. Is it inverted, or it is flat? I want to check if there is any surgical scar. I also want to check if there is any stigmata of chronic liver disease, such as spider nevi, capus medusae, spider telangiectasia. I want to check if there is anterior abdominal vein distension. All those things we have to be looked into under inspection. Then I also want to look at the nipple or the breast. For some men that have conditions like chronic liver disease, some of them can have what is called gynecomastia. This is done even before touching the patient at all, just on inspection. Now, when we expose the patient to the level of the mid-thigh, we want to check the hernia orifices, if there is any visible hernia. They also want to check the testicles. For patients that have chronic liver disease or some other gastrointestinal tract condition, they can have what is called testicular atrophy, where the testicle looks smaller than their age. Now, so I'm inspecting the patient's abdomen. The patient's abdomen looks very fine. He is a simulator, he's not a patient. It looks very fine, no distended abdominal vein. Then the nipple is flat, so there is no abnormality that is found there. The umbilicus too is flat. Let me quickly run through some abnormalities you can find specifically when I mention all these things. For the distended abdomen, there are 5 Fs that can cause distended abdomen. We have fats, we have fetus, we have flatus, we have fluid, and we have feces. So that are the 5 things that can cause distended abdomen. Now, for the umbilicus, if the abdomen is distended, the umbilicus will be inverted. If the abdomen is not distended, the umbilicus will be flat or inverted. In this case scenario now, we have a flat umbilicus. So that is that for inspection. Now, for palpation is divided into 2. It can be light palpation or deep palpation. For light palpation, before we go, we have to, before we start touching the patient, we have to ask if there is anywhere the patient is feeling for pain. So I have to ask my examinator if there is anywhere he's feeling for pain. So that place that he or she touches, that's the place that will be palpated last. Do you have anywhere that is paining you? So he said there is no place that is paining him, but let's assume that he has pain at the epigastric region. So that means I have to palpate that area last. Then I will start here. I have to palpate the 9 regions of the abdomen. Here, the right iliac fossa, right lumbar, right hypochondriac region, the suprapubic, umbilicus. Then I palpate the left iliac fossa, left lumbar, left hypochondriac region. So as I'm doing that, I should be looking at my patient face to check if there is any pain. So I'll go around then to check if there is any pain the patient is experiencing. Now, I have to go to the deep palpation. Deep palpation is to check if there is enlarged organ, or if there is enlarged mass, maybe the liver is enlarged, maybe the spleen is enlarged, maybe the kidneys are enlarged, or even the bowels, to check if they are enlarged. The three major organs we are going to check are the kidneys, the liver, the spleen, and the kidneys. How do we check for the liver? We start from the right hypochondriac region up. So I'll be looking at the patient face. I tell him to breathe in maximally, to also breathe out maximally. So at the points of maximal inspiration is when my hand will go in. Can you please breathe in and out? Okay, breathe in and out. Breathe in and out. Breathe in and out. Under normal conditions, physiologically, there should be no this the liver shouldn't be palpated, shouldn't be felt normally. Now that's for the liver. So we go like this, then up on the right, then up. Now I want to palpate for the spleen. Can you please breathe in and out? Breathe in and out. Breathe in and out. Breathe in and out. We should also take note that the palpation of the liver goes vertically, while palpation of the spleen goes diagonally. And in order for you to confirm if the spleen, okay, in order to confirm if the spleen is enlarged or not, once you go, can you breathe in and out? Breathe in. Thank you. Breathe in. Breathe in. So you tell your patient to move towards your side, to lie down on the right lateral side of the patient. Can you please lie down on your right lateral side and face me? Thank you. So you put your hand just below the left costal margin. So once your hand can enter into the left costal margin, that means that the spleen is not enlarged. So just like a confirmatory examination for the spleen to check if it is enlarged or not. Then you check for, still under deep palpation, you check if you can balance the kidneys or if you can palpate the kidneys. You put your left hand underneath, then your right hand should be on top. So you do like this. This is what we call bimanual palpation of the kidneys. Then you do like this, bimanual palpation of the kidneys. Now, you want to check for what is called the liver span. The liver span, that's under percussion. So we are done with palpation now. The liver span is under percussion. This is what you are going to do. You start your percussion from the second intercostal space. From the second intercostal space. And how are you going to guess where the second intercostal space is? You check for the sternal angle of Louis. Here, sternal angle of Louis. Just right below it is where the second intercostal space is. Check for the sternal angle of Louis. Right below it is where the second intercostal space is. So you put your finger, your middle finger should be lying on the second intercostal space, not all the fingers. So the middle finger, then you percuss. Then you go. Can you please let me put your hand here? So we can see that the sound has changed around this side. Then you start percussing also from the lower part of the abdomen, still with your middle finger. Then you use your tape rule. Sorry. Where's my tape? No. Okay. You use your tape rule. So still telling your patient to help you hold this side. Then you use the inches side to measure. The inches side, not the centimeter side. You use the inches side to measure, not the centimeter side, so that you won't be biased. Okay, please. Okay. So his liver span is 9 centimeter. Normal liver span is from 8 to 12 centimeter. In women, 8 to 12 centimeter. In women, it is 8 to 10 centimeter, while in men it is 10 to 12 centimeter. So cumulatively, normal liver span ranges between 8 centimeter to 12 centimeter. And here we have a simulator that has liver span of 9 centimeter, which falls within the normal liver span. However, before I move further into checking for ascites, which also comes under percussion, I want to quickly talk about the causes of enlarged spleen, enlarged liver, and enlarged kidneys. You can be examining the abdomen of your patients and you find out that the liver is enlarged, or the spleen is enlarged, or the kidneys are enlarged. For enlarged liver, we have conditions like liver cancer, conditions like alcoholic liver disease. We have conditions like hemochromatosis, conditions like hemosiderosis, conditions like sarcoidosis, conditions like that can cause enlarged liver. The liver will be enlarged way beyond 14, 15, 16 centimeter, even sometimes 20, 22 centimeter. Then what are the causes of enlarged spleen? Conditions like Kala-Azar, also known as leishmaniasis, can cause enlarged spleen. Conditions like Gaucher disease, conditions like glycogen storage disease, conditions like CLL, chronic lymphocytic leukemia, conditions like CML, chronic myeloid leukemia. All those things can cause enlarged spleen. Then the other conditions too that I mentioned under that could cause enlarged liver, hepatomegaly, can also cause enlarged spleen. What are the conditions that can cause enlarged kidney? It's not enough for the patient to have chronic kidney disease, but there are some conditions that can cause the kidney to be enlarged. Example, we have adults, autosomal dominant polycystic kidney disease, conditions like amyloidosis, conditions like diabetic nephropathy, conditions like amyloidosis, diabetic nephropathy, polycystic kidney disease, and so on and so forth. So the next thing to check for under percussion is ascites. For an abdomen that is not distended like this, we want to do what is called shifting dullness. Shifting dullness. So what you are going to do is that you put your hand at the umbilicus, then you percuss. The sound that comes out when we are percussing the abdomen is called tympanitic, as compared to the sound that comes out when we are percussing the chest. So this is a tympanitic sound. So if you have a patient that has ascites that is not too much inside the abdomen, we demonstrate it through what is called shifting dullness. Let's assume that we are percussing. I will notice that the patient, the dullness, the sound, the intensity of the sound changes around this place. Then we tell the patient to lie on the other side, on the left lateral side. Can you please lie down on the left lateral side? Assuming we have a patient that has ascites. So the patient lies on the left lateral side, and while doing that, you hold on for like 30 seconds. While your finger is still there, then you percuss again. So when you have done that, so you hear what is called tympanitic sound again. So that means the fluid has gravitated towards this side. Then you tell your patient to please, can you please lie down on your back again? So your finger is still there. Then you wait for 30 seconds. Then you still tap again. You percuss. Okay, so that's how to demonstrate ascites via shifting dullness. However, you can also have some scenarios whereby we have massively distended abdomen filled with fluid. So what we are going to do is that we can tell our patient to help us put the hand at the middle So put the hand at the middle. Can you please put the hand at the middle? Okay, this way. All right. Then you put your hand here. So you tap from this side. You tap from this side. So that is what is called fluid through. So that means there's movements of fluid from this side to the other side of the abdomen. This is done for massive ascites. What other ways can we demonstrate ascites? We can demonstrate ascites. We can find out if a patient has ascites through ultrasound scan. We can also find out if a patient has ascites through what is called the Podu sign. So after all said and done, we have to go ahead and auscultate. So that is the A part of the IPPA. We have to go ahead and auscultate for the bowel sound. For the bowel sound, because it's a low pitch sound, we use the bell of the stethoscope. We use the bell of the stethoscope. And where are you going to place your stethoscope? Just at the McBurney's point. And where is McBurney's point? It's midway between the anterior superior iliac spine and the umbilicus. Midway between the anterior superior iliac spine and the umbilicus. So just lateral 1/3. Lateral 1/3, midway between the anterior superior iliac spine and the umbilicus. So you put your stethoscope there. So you check for like 30 seconds because you might be told to do this during your examination. Now, so that's one part where we can check for the bowel sound. And what's normal bowel sound? Any sound that is less than, the normal bowel sound is between 1 to 3 in a minute. That's more active bowel sound. 1 to 3 in a minute. When your bowel sound is getting to more than 5 in a minute, that is hyperactive bowel sound. And when you count for up to 3 minutes and you can't even get up to 1 bowel sound, that is hypoactive bowel sound. Let me just quickly come again. Normal active bowel sound is in a minute, 1 to 3 in a minute. That's normal active bowel sound. Hyperactive bowel sound is from 5 bowel sound and above. That's hyperactive bowel sound. Now, for hypoactive bowel sound or absent bowel sound is when you are still counting as at 3 minutes, you can't even get up to 1 bowel sound. So that is hypoactive bowel sound. So that's, you check the McBurney's points for a place where you can find the bowel sound. Then other places where you want to auscultate, you check what is called the renal buoy for patients that have renal artery stenosis. You go 1 finger breadth lateral to and superior to the umbilicus, 2 centimeters above and superior to the umbilicus. So put your stethoscope there. Use your diaphragm. Use your diaphragm. Then you check again. Another place where you want to check for, when you want to auscultate on the abdomen, is the aorta, abdominal aorta, to check for aortic buoy for patients that have aortic aneurysm. Okay. Now, if you have a patient that has hepatomegaly or you are suspecting a case of primary liver cell carcinoma, you want to check what is called the hepatic buoy also, so which will be auscultated at the right hypochondriac region. Okay, so that's about the examination of the abdomen. However, your examination is not complete until you do what is called the digital rectal examination for your patients. And how do you do digital rectal examination? Just like you are starting all over again, you want to take consent, you want to explain whatever you want to do to the patient, that I would like to check through your rectum, and it will involve sticking your finger into the rectum of the patient. How are you going to position your patient? That's what I want to do now. I won't do the digital examination for him, but I have to position him in a way that the procedure, the examination is being done. So I will have to demonstrate what I want to do. I won't bother to, okay? So I want you to lie down on your left side. Okay. So you have to straighten this, straighten your left leg. So straighten it then. I have to flex. Okay. You have to flex. So the left leg will be well straightened, while the right leg you have to be flexed. So what you are going to do is that the examination of the for genital rectal examination too, IPPA also. So you want to inspect. What are you trying to inspect? You inspect the perianal region. Is the perianal region, is there good hygiene around the perianal region? Is there warts? Is there anal tag? Is there hemorrhoid? So those are the things you want to check out for around the perianal, still under inspection. Then before you do that, you will have been gloved. You wear double gloves on the examining finger. After you check, you pat the anus, then you stick in your finger facing towards the upper part of the body. You stick in your finger facing towards the upper part of the body. So once you get inside, you turn your hand facing the anterior rectal wall. Let me come again. You stick in your finger facing towards the upper part of the body. Then you turn your finger facing the anterior rectal wall. Before you start checking for the anterior rectal wall, you want to check for what is called the sphincteric tone. Normal sphincteric tone is supposed to grip your finger. It should not be loose. However, we have some situation whereby the sphincteric tone is loose or passulous. Situations like colorectal carcinoma can cause loose sphincteric tone. Then we have some situation whereby the sphincteric tone is too tight. We have situations like anal fissure, in which the sphincteric tone is too tight. So when it gets into the rectum, you check the anterior rectal wall. The anterior rectal wall normally shouldn't be painful. If you are doing a genital rectal examination for your patient and it is very painful, suspect colorectal carcinoma until proven otherwise. Then if it is a man that is way above 40, 50 years, 60, so you want to check for the prostate. Is the prostate firm? Is the prostate hard? Is it, can you feel the median groove? Can you feel the lateral sulcus? And so on and so forth. If the prostate is hard, is it nodular? Is it craggy? Is it painful? So all those things you want to check. So for genital rectal examination. I've already mentioned some of the indications for genital rectal examination while I was trying to explain this. So let me just quickly run through them. Benign prostatic hyperplasia is an indication for genital rectal examination. Prostatic cancer is an indication for genital rectal examination. Colorectal carcinoma is an indication for genital rectal examination. A patient that has melena, that is passage of dark tarry stool due to upper GI bleeding, is an indication for genital rectal examination. A patient that has hemorrhoid is an indication for genital rectal examination. A patient that has diverticulosis, there are many, so it's really countless. So those are indications for genital rectal examination. And when you are done, you try to reposition your patient's back, and then you thank your patient. But before I leave this, before I conclude on abdominal examination, I want to do what is called the renal angle tenderness for your patients, also called the costovertebral angle tenderness. So you tell your patient to please sit up. Can you please sit up and just face the front part of your view? Then you tap, you hit where the kidneys are. You hit where the kidneys are. Then you hit where the kidneys are. Hit where the kidneys are. Hit where the kidneys are. If there is any form of tender, okay. So you tell the patient to face the anterior part of his or her view. Then you tap, you hit where the kidneys are. You also hit where the kidneys are. So you hit. At the same time, you don't want to inflict too much pain on the patient. So you hit. So if there is any form of tenderness, it's in keeping with pyelonephritis, which could be acute or chronic pyelonephritis. Then, vertebrae, okay. So the landmark for where the kidney is, we feel for the iliac crest. You feel for where the iliac crest is. Then also feel the vertebra, the lower parts of the 12th rib. The lower part of the iliac crest, in between the iliac crest and the lower part of the 12th rib. So that's where you are going to hit. So on the other side too, in between the iliac crest inferiorly and the lower parts of the 12th rib superiorly, then you hit. So if there's any form of tenderness, it is keeping with acute pyelonephritis. When you are done with examining your patient, you thank your patient, then you go ahead to sanitize your hand. You sanitize. Thank you very much.
So, excuse me, ma. While you were doing the examination the other time, you asked the patient to place his hand at the center of his abdomen.
Yeah.
So, I was curious as to the reason
Okay.
why you asked him to do that.
Okay. The reason why I want your patients or the examinators to put the hand at the center of the abdomen is for the fluid in the abdomen to be dampened, so that by the time you put your hand here, so there will not be excessive movement of the fluid from just like you are putting the fluid in a static position. So that's the reason why I tell the patients to or the examinator to put the hand here. So if your patient is weak, so weak that he or she cannot put the hand there, so you can ask for an assistance. You can even inform your examiner politely to help you to put his or her hand on at the center parts, not just anywhere in the abdomen, at the center parts of the abdomen.
Okay.
Yes.
Yeah, you can.
So, sorry, ma. Concerning the DRE, the digital rectal examination, I wanted to ask, how many fingers can we use for the DRE?
Okay. Just like I said earlier, before you do a digital rectal examination for your patient, make sure that the examining finger, you are wearing double gloves on the examining finger and then only one glove on the other finger. You are using just only one finger. So one finger is going inside the anus, just the index finger is going inside the anus for digital rectal examination.
Thank you, ma.
Hi, good afternoon. I'm Dr. Adeleke. I would like to do an abdominal examination on you. May I go ahead? All right. I would like to sanitize my hand, and I also want to screen my patients. So on inspection, the abdomen is flat, smooth respiration, no area. The abdomen is flat, smooth respiration, no distended abdominal vein, and the umbilicus is inverted. So I want to go to like palpation now. Is there anywhere that is paining you? All right. So there is no tenderness unless palpation. I also want to check for the palpation, okay? So can you please breathe in and out? Breathe in, breathe in, breathe in. Can you breathe in and out? Breathe in, breathe in, breathe in, breathe in. On the palpation, the liver, the spleen, and the kidneys are not palpably enlarged. So I want to check for the liver span. So I want to check for the liver span. I have to locate the sternal angle of Louis. Then just below it is the second intercostal space. Can you please let me put your finger here? Yes, thank you. So I'm going to use the inches side to check for the liver span. Then I will turn it around using the centimeter side. So his liver span is 9 centimeter, which is within the normal, which is in keeping with normal liver span. Normal liver span is 8 to 12 centimeter. Then I also want to demonstrate for ascites by shifting donors. Can you please move to the other side? Thank you. Can you lie down back? Thank you very much. So I want to auscultate by auscultating at the McBurney's point, which is 1/3 lateral, just between the anterior superior iliac spine and the iliac fossa. I'm going to use the bell of my stethoscope. The bowel side is more active. I also want to check if there is renal artery stenosis, which is if there is renal bruit, which is in keeping with renal artery stenosis bilaterally. I'm going to use my diaphragm for that. There is no renal bruit bilaterally. I also want to check if there is aortic bruit. There is no aortic bruit. If you have a patient that has an enlarged liver, hepatomegaly, we want to check if there is hepatic bruit, but it doesn't have, so we are going to skip that. But for academic purpose, this is where to check for hepatic bruit, assuming the liver is enlarged to this extent. So just put a stethoscope here to check the hepatic bruit. Now, before I go to the rectal examination, I want my patient to sit up and I'll check for the renal angle tenderness. Can you please? Thank you. So the renal angle, the location of the kidney is just between the iliac crest inferiorly and the lower border of the left rib, of the 12th rib superiorly. Between the iliac crest inferiorly and the lower border of the 12th rib superiorly. So I'm going to hit that side, not too much. Then I check the other side too. The lower border of the iliac crest. The lower border of the kidney is at the iliac crest inferiorly and the 12th rib superiorly. So I'm going to hit, not too much. So if there is any pain or if there is tenderness around where the renal angle is or the costovertebral angle, if there is any tenderness or pain, so it is in keeping with pyelonephritis, which could be acute or chronic. Please, can you lie down again? Thank you. And before I round off my examination, I want to do dictal rectal examination for my patients. Do I have to? Okay. So, all right. So I will have to demonstrate how to do it. Then please, can you face the other side? Can you lie down your left lateral side? Okay. Thank you. So this left leg will be straightened while the right leg will be flexed. Then, if I want to demonstrate that, I will have had 3 gloves with me, 2 gloves on the examining hand and 1 glove on the other hand. I will put my lubricants on this non-examining hand. Then I will have to be generous with my lubricants. Then only 1 finger you have to go. So I want to check the perianal region for warts, for hemorrhoid, and for anal sag. Then I stick in 1 finger, facing towards the upper part of the body. Then I turn around, then check if there is any anterior wall tenderness. So on the rectal examination of these patients, there is good perianal hygiene, there is good sphincteric tone, there is no anterior rectal wall tenderness, the prostate is not enlarged, and the examining glove is stained with brownish stew. So I've come to the end of the examination. Thank you very much.